Dear colleague, welcome to this lecture on IPG replacements. To change an IPG may seem as a simple procedure, but avoidable complications are common, and even though the consequences of complications may be severe, this procedure is often left to the youngest colleagues. I hope that this rather detailed lecture will be helpful in avoiding some of these complications. Further, the new hybrid systems with combinations of different brands are providing new possibilities, but they also increase the complexity of the procedure, which is why we will look at this in some detail. Replacing an existing IPG with one of the same model is most common and needs no further comments. Hybrid systems, that is most commonly replacement of an older Medtronic IPG with a new IPG from Boston Scientific or Abbott, have hitherto been more unusual, which is why I will say a few words about these. After having used non-hybrid systems for more than 20 years, today almost all my IPG replacements are hybrids. There are of course many reasons why one might consider to use a hybrid system, and in my case considerations regarding battery longevity and programming related properties were the most important. However, this equation will be different from center to center, and I will not try to make a comparison between different systems here, but just to focus on some practical surgical aspects. One of the reasons as to why I did not start with hybrid systems earlier was that this was previously more time-consuming than non-hybrid systems. When we changed from Activa PC to Activa PC, we would just program the new IPG before surgery with the same settings and send the patient home the day after surgery. When changing from Activa to Versailles or Infinity, the stimulation settings are not exactly the same, especially since our patients with Activa PC are programmed with constant voltage. Even if we follow the conversion table from volt to milliamp, minor adjustments of the current may be necessary before sending the patient home. Further, we need to teach the patient how to manage a new patient controller, and this can be quite a challenge in an old, maybe demented patient. However, now when Medtronic has changed from Activa to Percept, it is necessary for us both to reprogram the patient and to teach them how to use the new two-component patient controller. Thus, it is no longer more time-consuming to change instead to a hybrid system. As I see it, the only real disadvantage with hybrid systems is that they are not what is called MRI compatible. However, often an MRI can be replaced with another investigation, such as CT. Further, the hybrid system is in reality not MRI incompatible. The compatibility has not been tested and is not guaranteed by the manufacturer, and this is by many understood as the system being incompatible with MRI and that MRI is impossible to perform. In reality, there is every reason to expect these to be compatible. Hence, when needed, we will perform an MRI on a hybrid system on our own responsibility. This has been a joint decision between myself, the neuroradiologist, and the MRI physicist. With cardiac pacemakers, leads and pacemakers from different companies are often combined, and MRI is often done in these patients. This is a development that has been led by the medical profession and not by the manufacturers, and I hope that we will see the same development in DBS. However, this is a question on which each individual center must make up its own mind. Anyhow, let us now look at the different hybrids. If we have decided that we want to replace a Medtronic IPG with an Infinity, we then need to decide if we should use the big Infinity or the small Infinity. Remember that both of these can be connected to two electrodes, so it is only the size and battery longevity that differs. We need also to look at which contact model the patient has. Patients with the old contacts used in Medtronic's Kinetra and Soletra are connected to the Infinity standard model by using an adapter. Patients with the more modern contacts using Activa PC and SC are connected directly to a special Infinity model with pre-adapted connection. Some patients will already have a Medtronic adapter from the old model to the new model. Here, the Medtronic adapter can be connected to the Infinity with pre-adapted connection, or one can replace the Medtronic adapter with the Abbott adapter and connect it to the standard model of Infinity. This might seem simple enough, but in order to get everything right, it is necessary not only to look at what model of IPG the patient is currently using, but to look also at what was the first model the patient received and if any changes, including implantation of adapters, has been made over time. Let us therefore repeat this. If the patient started with Activa RC, PC or SC, then you just use the adapted Infinity 6661 or 3 without adapter. And remember that Activa SC came in two models, and we are here speaking about the 37603 with the modern connection. If the patient started with and still has Medtronic's Kinetra or Soletra, then you use the Abbott adapter and connect this to an Infinity 6660 or 2. Most patients that started with the Kinetra or Soletra will, however, have changed their IPG to the next generation of IPGs from Medtronic. Some of them have an Activa SC model 37602 with the old connection, and is thus replaced by using an Abbott adapter and connected to Infinity 6660 or 2. More commonly, the patient will have received a Medtronic single or double adapter connected to Activa RC, PC or SC model 37603. You can retain this adapter and connect it to Infinity 6661 or 3, which is the most easy solution, but it is also possible to replace the Medtronic adapter with the Abbott adapter and connect it to 6660 or 2. A good piece of advice is to not open the new IPG before you have verified during surgery that everything is as expected. If we have decided to replace a Medtronic IPG with Versailles, then we need also to look at which contact model the patient has. Patients with the old contacts used in Kinetra and Soletra are connected to the Versailles by using the adapter seen here, while another adapter is used in patients with the modern contacts used in Activa, RC, PC and SC. So, if the patient started with Activa RC, PC or SC 37603, then you just use the Boston adapter for modern connections. If the patient started and still has Medtronic Kinetra or Soletra, then you use the Boston adapter for all contacts. The same is true if the patient has changed to an Activa SC model 37602 with the old connection. If the patient has changed to a Medtronic single or double adapter connected to Activa RC, PC or SC model 37603, you can retain this adapter and add the Boston adapter for modern connections, or you can replace the Medtronic adapter with the Boston adapter for all connections, which is probably a better option. An IPG may be changed for other reasons, such as increasing the programming options, but most often it is replaced when the battery is close to depletion. When the IPG is warning for low battery, we will recommend the patient to check the status once a week. In patients with essential tremor or with unilateral DBS for tremor or dominant Parkinson's disease, we normally wait until the IPG is close to depletion or loss of effect due to battery depletion. The IPG is then replaced within 1 month or earlier if loss of effect due to depletion. In bilaterally implanted patients with severe symptoms from Parkinson's disease, dystonia or psychiatric disorders, we will follow the recommendations from the manufacturers. Let us also have a look at how we replace an IPG. In the literature, the reported infection rate has often been high, often around 10%. But when we looked at the rate in almost 1,300 replacements performed with a similar technique, we found it to be 1.7%. I have personally made about 400 IPG replacements with no post-operative infections, at least no clear infections necessitating removal of the IPG. And I personally believe that differences in technique are partly responsible for the differences in outcome. If an infection occurs, this will lead to a high cost and suffering for the patient, since the implants will have to be removed. And in patients too old for a new procedure, this might result in years of suffering. So even though IPG replacements is technically simple, it should be considered a difficult procedure considering the consequences of infections and erosions. IPGs can be implanted at various locations, but when changing an IPG, we will normally use the existing location. The procedure can be done in general anesthesia or in local anesthesia. In the latter case, we will make a sort of tent around the patient as seen here. Local anesthesia is infiltrated into the old incision, and it is important to palpate the area before starting the surgery in order to identify any cables above the IPG that are at risk of being damaged during surgery, as seen in these images here. We then open the skin down to the subcutaneous fat. We continue down to the capsule that has formed around the IPG. The white capsule, as seen here, is then opened. I prefer to make a small incision in the capsule with a knife and then to cut it open with scissors. But look carefully so that you are not cutting the cables. We can then remove the IPG. If it's slippery, grab it with a cloth. If you are inserting a new pacemaker with an adapter, and in some other patients, the pocket will be too small for a new implant, making it difficult to close the wound. In these cases, you will have to open the capsule also under the IPG. Especially if you are inserting a new IPG of the same size and adapters, then you might want to enlarge the pocket further. And often I find it easiest to open the capsule in the bottom and enlarge it a couple of centimeters. The extension cables will often be at least partly embedded in the capsule under the IPG, and sometimes it might be difficult to see exactly where they are, so be careful if opening this. We will not free the cables if we don't need to. However, sometimes it is necessary in order to open the capsule or to get a less superficial location of the cables. In such cases, work carefully with the hook and scissors in order not to damage the cable, and don't free more of the cable than you need. Sometimes, if the capsule is not adhering too tightly to the cable, the easiest manner is to remove the cable from the IPG, then find an exposed part of the cable as close as possible to the end and just pull it backwards. At other times, this is not possible. Below we see what happened at one occasion when we pulled the cable backwards. We ripped off the two most distal contacts. When the capsule is thin, then a hook works well. When thicker, then the best manner is to insert the scissors along the cable and then open them in order to rip apart the capsule. When it is impossible to insert the scissors, then we will cut our way to the electrode with the scissors, and sometimes in a thick and calcificated capsule it is better to cut loose a chunk of a capsule with embedded cables instead of freeing them completely, as seen in the rather extreme example to the right. I also advise you to remove one extension cable at a time in order not to mix them up. So let us look at a short video of IPG replacement without adapters. In this case, I am replacing an Activa SC with an Infinity, but it might as well have been a non-hybrid system. Here we remove the old IPG, we open the screw and disconnect it from the extension cable. The cable is then inserted into the new IPG. And make sure that the lock screw is opened. And you can then insert the cable to the bottom of the socket. We then lock the screw and then we verify that the impedance is okay. And the new IPG is then put in place. Let us look again at the video when using adapters. I prepare the Versailles IPG by inserting the adapter cables and locking the screws. We then remove the old IPG and disconnect it from the extension cables. The old extension cables are then connected with the adapter by inserting them into the new connector of the adapter and locking the screw. The next step is to seal the cover over the screw by applying a drop of silicone over it, which is only done in this type of hybrid systems due to slight differences in the systems. And then we have a complete system. Even though this is very simple, it is not unusual for unexperienced users to make mistakes, which will sometimes lead to hardware damage and malfunction. So let us look at some details. The end of the extension cable is reinforced and stiff in order for it to be easy to introduce into the socket of the IPG. If it is difficult to introduce the connection cable into the socket, then start with opening the lock screw. It should now be easy to introduce the cable and push gently a few times extra in order to make sure that it has reached the bottom of the socket. Since the plastic is transparent, we will also look to see if the last metal contact on the cable where the lock screw is fastened is fully inserted into the corresponding metal contact in the socket. If the cable contact is not fully covered by the socket contact, then push it a little bit deeper and then lock the screw. If you do not lock the screw, this might affect the impedance reading when we are dealing with a hybrid system. However, when dealing with non-hybrid systems, it is sometimes suggested to do the reading before locking the screw, in order to avoid possible injuries to the cable if the screw is tightened over the wrong part of the cable. However, I believe that this risk is small if you look at what you are doing, and on rare occasions locking the screw will change the location of the cable, or at least the reading enough to affect the impedance, so I prefer to measure this only after we have locked the screw. When introducing the cable, hold it in a pincer grip. The closer to the end you hold it, the easier it will be to introduce. If it is difficult, hold it just a few millimeters from the end and feed it into the socket in small steps. If it is difficult to introduce the cable despite using this technique, and even though you have opened the locking screw enough, then you might try the insertion tool provided by Abbott. I myself have never needed this, but I have tested it and it can be helpful. Place the cable in the groove in the tool and close it. The tip of the tool should be about 2 mm from the closest contact. Now keep the tool locked around the cable and introduce it into the socket. And the tip of the tool itself should be introduced into the socket. When the cable is in place, then lock the screw. You can then gently retract the tool and remove it. When retracting the tool, don't press it together so it is locked around the cable. It is possible for the reinforcement around the end of the cable to break, especially after years of wear and tear, and we will then have a soft and flappy end. However, if you use the insertion tool, or for that matter your fingers, and place it close to the end, then you can introduce the cable into the socket a couple of millimeters at a time, and then this should not be a major problem. Also remember to use the dedicated plug to seal the other socket on the IPG if you have only one extension cable or a double adapter using only one of the sockets. So, as I mentioned, we test the impedance after having tightened the lock screw. And note that the IPG from Boston Scientific needs to be in direct contact with the body when testing the impedance. The impedance is tested with the patient's remote control in Boston and with the patient programmer in Abbott. You can dress these and manage them yourself, but it is easier if they are not dressed but managed by someone else at some distance. When using the Envision, we will dress this since it needs to be placed directly over the IPG. If the impedance is not okay, then correct the location of the cable within the socket in order to solve the problem. And of course, you should have tested impedance also before the procedure, so that you know if you have a pre-existing problem. I will not go into detail how the impedance is measured with the different devices. However, remember that if you have an old electrode with 4 contacts in the brain, and you connect this with a modern IPG designed for electrodes with 8 contacts, then you will of course still not get good impedance readings from more than 4 contacts. If you need more information about the testing, then you will find dedicated lectures at the Stereotactic Academy. The different models of IPGs have 2 holes in the top for suturing. This is seldom necessary when changing the IPG, since in most patients we have a firm capsule around the pocket. However, in patients with loose subcutaneous tissue, it might be a good idea to suture the IPG to the upper part of the capsule with a silk ligature. Another option, if this is a problem, is to simply place the IPG under the muscle. However, sometimes even this is not enough, and in one patient with Whittler syndrome, I was eventually forced to anchor the IPG to the clavicle, as seen here. Before suturing, the wound is rinsed with hydrogen superoxide and then sodium chloride solution. In order to avoid infections and erosions, it is important to get a good cover over the implant. And if necessary, more subcutaneous tissue can be mobilized. There should be no tension in the wound, so that you need any force to close it. If it is difficult to get a good cover, one might, as mentioned, place the IPG under the muscle. Divide the muscle along the fibers. This is done mostly bluntly with fingers and hooks, but sometimes diathermia and cutting of minor sections is helpful. At the bottom of the muscle, you will reach the fascia over the rib cage. This can be penetrated with a finger, and when you are under this, it will be easy to create a pocket by simply using your fingers. If it is difficult, then you have probably not penetrated the fascia. We use inverted sutures for the subcutis and cut is very short. When the subcutis has been stitched, it should cover the implants completely, and preferably the edges of the wound should have come together even before closing the skin. The skin can be closed in different manners. We prefer single sutures spaced 10 mm apart, but intercutaneous sutures are probably preferable from an aesthetic point of view. Staples are very fast, but I believe that this comes at the price of a slightly increased risk for complications. We have also tried glue, which is fast and has many advantages, but for psychological reasons I find it difficult to trust. Besides a good cover, antibiotics are probably very valuable for avoiding infections. My patients receive a single dose of 3 grams of cefuroxime during surgery. I do not use antibiotic solutions in the wound, but Marwan Haris has kindly told me that at Queen Square they were able to reduce the infection rate in IPG replacements from 8% to 0% by using a solution of vancomycin wash in the wound prior to closure. And here to the right you see the recipe for Queen Square's magic solution. Depending on the specific model, the IPG is implanted in the on mode or is started during the implantation after we have checked the impedance. Normally we will implant the IPG with the same parameters as used before, but with the current 0.3 to 0.5 milliamps below normal. Many patients will otherwise respond with minor stimulation-induced side effects, mainly paresthesias. The patient is also provided with a window should they wish to make minor changes immediately after surgery, and the DBS nurse will increase the current to the normal value the morning after surgery. The patient is discharged home the day after surgery, and the sutures are removed after 14 days. Concerning how to avoid and manage complications, this is discussed in detail in the dedicated lecture seen here. And with that I end this lecture. Thank you for your attention.